You are listening to Medscape's In Discussion series on colorectal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Benjamin Schlechter. Dr. Schlechter is a senior physician in gastrointestinal oncology at the Dana-Farber Cancer Institute. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Benjamin Schlechter, and welcome to Medscape's In Discussion series on colorectal cancer. Today, we're discussing adjuvant chemotherapy for colon cancer with our guest, Dr. Jeffrey Meyerhardt. Dr. Meyerhardt's a gastrointestinal oncologist at the Dana-Farber Cancer Institute and the clinical chief research officer, as well as the Douglas Gray Woodruff Chair in Colorectal Cancer Research and a professor of medicine at Harvard Medical School. Dr. Meyerhardt is also a recognized expert in the care of colon cancer patients and serves as co-chair of the GI Committee of the Alliance for Cancer Clinical Trials. Before we start a discussion about adjuvant therapy for colon cancer, I first want to hear a bit about your pathway to becoming a GI oncologist.
So thanks for having me. I guess my initial pathway to oncology was probably started even in college, where I had done research primarily in wet lab bench research related to cancer. And so that sort of initially piqued my interest in oncology. And then I, during med school, had done a rotation in pediatrics, actually in pediatric oncology, that sort of initially piqued my interest. As tough as it was still a really fulfilling rotation. And that sort of led me initially, as I went into residency, thinking that I may focus on oncology. I continued doing bench research throughout med school. And when it came time to thinking about fellowship, that's where I went in oncology. And I actually thought initially I would focus on bench research and not necessarily specialize. But as I went through my first year of fellowship, I sort of gravitated towards both oncology and also research that was more clinical research and initially focusing and still focus on epidemiology and outcomes research, really a lot through the mentorship of Charlie Fuchs, who was at the Dana-Farber at the time and doing studies of large observational studies. And so that sort of is what kind of wound me into GI oncology, both sort of the mentorship as well as sort of the diversity of diseases we treat and the research needs of it.
That's one of the themes, I think, throughout this series. I ask everyone this question, and time and again, mentorship and education comes up as sort of how oncologists end up as GI oncologists and how med students end up as oncologists. I think that emphasizes the importance of exposure to trainees to GI oncology in particular and oncology in general. And it's just an important point as we go through this series that we need young doctors to see what we do so that they become oncologists and help with these diseases.
Yeah. And again, I think emphasizing mentorship, I mean, I think some do it really well. And I think each of us just strive to really sort of set the time aside to really help people as they develop their careers.
Absolutely. So let's get to the topic today. Let's talk about adjuvant therapy. Our gold standard is FOLFOX, and there have been a number of efforts to demonstrate the benefit of FOLFOX in resected colon cancer. I think probably the most important thing to discuss is the MOSAIC trial published in the New England Journal by Terry Andre and colleagues in 2004. So this examined the impact of FOLFOX versus 5-FU and leucovorin in stage 2 and stage 3 cancers. It's a large study, 2,246 patients, randomized 1-to-1. And FOLFOX was the clear winner in stage 3 disease, although outcomes in stage 2 were a little bit less significant, shall we say. So can you highlight some of the key findings from MOSAIC and how this informs your practice?
Yeah, so I agree that MOSAIC was sort of where we started in terms of using oxaliplatin and fluoropyrimidine. Concurrently, there were 2 other trials, as you know, that also use a different delivery method of fluoropyrimidine with oxaliplatin, both the NSAP study and then a study with capecitabine oxaliplatin, which fortunately all had similar results in terms of the additional benefit of oxaliplatin with a fluoropyrimidine. And at the time, and we'll go into this a little later, the standard was to give a fluoropyrimidine with for 6 months, and so that logically added when you added oxaliplatin to that. MOSAIC, was published in the New England Journal in 2004. As you point out, for stage 3, there's clearly an additional benefit. The way I think about it for stage 3 disease is if you take all stage 3 patients, about 50% of patients will be cured with surgery alone, remaining disease-free long-term, and 50% will recur. If you add a fluoropyrimidine, you bring that number up to about 65% remaining disease-free long-term. And the addition of oxaliplatin adds about an additional 7% for stage 3 disease. Now, again, there's, stage 3 disease that has only one lymph node, and there's stage 3 disease that has 10 lymph nodes, and there's stage 3 disease at T2, and there's stage 3 that's T4, which will have variation in those numbers. But in general, you're thinking about some modest but significant benefit over fluoropyrimidine only. Stage 2 is more complicated, and so for stage 2 patients, again, there's controversy just regarding the benefit of adjuvant therapy overall, particularly for better risk stage 2 patients. For higher risk, T4 disease, poorly differentiated, clinical bowel perforation, clinical bowel obstruction, those patients seem to have some benefit from adjuvant therapy, somewhere probably between 0 and 5%. And the study, Mosaic also has now led to multiple publications looking at different subgroups, including stage 2 and higher risk stage 2, where statistically there wasn't a difference, but numerically there's still a difference in terms of overall outcome for those patients. So just looking at, if we look at the 10-year results, for example, for the high-risk stage 2 disease-free survival, about 73% versus 67%. Not statistically significant, but numerically still showing about that 6 to 7% additional benefit in terms of disease-free survival long-term.
That's a great reminder that 5FU actually does a lot of work. We live in an era of very sophisticated and modern drugs, and sometimes good old-fashioned 5FU still has an important place in colorectal cancer and in GI cancers broadly. And so it's really not just FOLFOX, right? That's the combination. And so I always like when we get those reminders.
Yeah, absolutely. And patients ask you, it hasn't been around forever, and it's over 70 years, but it's still, within a lot of GI cancers, it's still a beneficial drug.
And how was tolerance for FOLFOX? It's a great opportunity to look at tolerability of FOLFOX compared to relatively well-tolerated control, as opposed to some of the more escalated regimens. How did people do in Mosaic?
So, in general, for us, you and I, and many others who give oxaliplatin with fluoropyrimidine, it is a reasonably well-tolerated regimen. Everyone's different. There are some people in terms of nausea, diarrhea that have a tougher time. There's pretty good supportive medications to get people through the toxicities that are the shorter term. The major problem with oxaliplatin is the neuropathy. As I describe it to patients, the cold-induced neuropathy, which nearly everyone gets to some degree, touch something cold, feel like kind of pins and needles, or shock symptoms to your fingers, drink something cold, feels like little shards of glass on your tongue. Those are manageable in that you figure out what bothers you. You haven't damaged any sensory things. You haven't damaged your fingers. You haven't damaged your tongue. And you kind of figure out particularly for the first few days, how to get around it, and whether you have to have things only in the fridge but no ice, things a little warmer. The more worrisome is the cumulative neuropathy. And we've seen that sort of in countless different publications in terms of looking at the time course of neuropathy for patients, both from the Mosaic and other trials, where a large number of patients will have some level of neuropathy at the end of treatment. And even when you go 4 years out, 15% of them will have still grade 2 or 3 neuropathy with 6 months of therapy. So, that is the major concern. And it's not a predictable neuropathy always, in terms of it is cumulative. You can see it. And then we all learn that even if you stop oxaliplatin for the last several treatments, it can actually get worse in the first 3 months or so until it sort of levels off. And then very slowly over time, months to years, can improve, but for some patients not resolve and still have effects on function.
Yeah, thanks for that reminder. And this is clearly important data. We have 6 months of therapy. That was a gold standard for well over a decade. At the same time, several efforts were undertaken in stage 3 disease to look at ways to optimize benefit and minimize toxicity. So let's talk about the IDEA Collaborative, also published in the New England Journal by Axel Grothe and colleagues in 2018. This was a really impressive effort. There were 6 clinical trials pooled, and they all had similar design: 3 months of FOLFOX or CAPOX versus 6 months of FOLFOX or CAPOX, plus or minus some other agent to try and boost the benefit of adjuvant therapy. The sad thing is that none of those other boosters worked. but there was some really important findings of 3 months versus 6 months of therapy. So can you help us contextualize IDEA and how this informs practice in the modern era?
Yeah. So as you pointed out, the rationale for this was severalfold. One is ideally if you can get away with less adjuvant therapy, great in terms of sort of costs and inconvenience to patients, and the neuropathy issue. How this came about when adjuvant therapy first sort of evolved in colorectal cancer, we did it for a year, just a fluoropyrimidine. We learned then 6 months was as good as a year. And then again, with the addition of oxaliplatin, the question is, does everyone really need 6 months of therapy? It's 6 trials. One was done in the United States. I helped chair that one. There was 4 done in Europe and then 1 in Japan. And it was, I agree, it was an impressive effort that there was an agreement across the different studies. 2 of them had already really been up and running when the collaboration began, both the study out of Italy, led by Alberto Sabero, and the Scott study in the UK. The other studies sort of essentially evolved as efforts to support and contribute patients to this. And I think there's a few things to sort of note in the study. There was agreement that looking at 3 versus 6 months of therapy. Because of sort of practices that occurred, multiple of the studies wanted to give the option of a capecitabine as the fluoropyrimidine with oxaliplatin versus an infusion regimen of FOLFOX. The United States study was only with FOLFOX, but every other study had patient and physician preference. And it there's a little interesting in that is 90% of the patients enrolled in Japan got capecitabine oxaliplatin versus 90% of patients enrolled in France got FOLFOX. And then the other studies had somewhere in the 2/3, 1/3 distribution. No one thought there'd be a difference. There was, the study that came out from Cassidy and Saltz for metastatic disease showed there was no difference in efficacy between capecitabine oxaliplatin and FOLFOX. So they weren't randomized in any of the studies. They were purely physician choice, which, brings up some interesting interpretations of the results. The study was designed to look at non-inferiority. You can't in medicine show that something's exactly the same. Just statistically, it's sort of not how we think about things. So we do non-inferiority where we accept there may be some acceptable difference between the two treatments, but it's acceptable difference, weighing against the alternative. This was set up as a non-inferiority trial where we accepted a small difference of about 2.3%, if I remember correctly, but in disease-free survival. And that's based on the upper limit of the confidence interval to show non-inferiority. And the plan was to initially pool all the patients with stage 3 disease. 4 of the trials included stage 2, but the initial plan was to include just stage 3 disease. The United States and the France trial was only stage 3 patients. The overall trial did not meet the criteria for non-inferiority. We did not prove non-inferiority between 3 versus 6 months. But then there was planned analysis both to look at capecitabine oxaliplatin versus FOLFOX, even though that was not randomized, as well as to look at the severity of disease in terms of staging within stage 3 disease. We ultimately created these 2 risk groups, and those were really based on the data in terms of who was higher risk of recurrence. So the T1 just through the mucosa to T3 through the muscle layer into the fat, N1 no more than 3 lymph nodes, so 1 to 3 lymph nodes, versus either having T4 all the way through or invading another organ, or N2 disease, or both N2, 4 or more positive lymph nodes. And so what we found is for the better risk patients, particularly if they got a capecitabine oxaliplatin, non-inferiority was reached, and really the curves are on top of each other. For the higher risk patients, the T4 and N2s, those patients did seem to have a small additional benefit to going to 6 months of therapy in the assigned arm. Now, the reality is if you look at all the curves across this study, they're all differences of, 1.5%, like very small differences, whether you give 3 versus 6 months. But again, I think in my own practice, the better risk patients, I'll offer capecitabine oxaliplatin for 3 months. For higher risk patients, I give 6 months of FOLFOX, or I offer 6 months of FOLFOX, 6 months of CAPOX is also totally appropriate as well, just sort of how I think about interpreting the results.
It's funny. I've seen a lot of different ways people practice from this. So like you, I also offer 3 months of CAPOX for lower risk disease. For higher risk disease, I offer 6 months of FOLFOX. I do the same thing. I've seen patients come to me where their providers universally are offering 3 months of treatment because they see this as favoring that. I've also seen providers who just reject it outright and really feel that 6 months of therapy is adequate. And then we have this other population who seem to get 3 months of FOLFOX or CAPOX and 3 months of fluoropyrimidine alone. And that's sort of an interesting approach. Are you willing to comment on that, or is that so far beyond the data that we just shouldn't go there?
No, that we actually published separately on that. So Claire Gallese published on this in the JCO last year. Specifically, they created 2 terms: early discontinuation of therapy and early discontinuation of oxaliplatin therapy. So early discontinuation, like all chemotherapy, versus early discontinuation of oxaliplatin. And I think early discontinuation of oxaliplatin was for the 6-month patients to at least have gotten 3 months of therapy. And what we saw and what she published in the JCO was that early discontinuation of therapy overall was associated with poorer outcomes. However, that was not the case with early discontinuation of oxaliplatin, that you still see those patients seem to benefit as much as patients who had a longer continuation of oxaliplatin. And I think it brings up that it's still reasonable to individualize therapy based on different needs. We don't know what all those, individualizations should be. Like, should a younger person definitely get at least 6 months? The data wouldn't actually suggest that that's necessarily true. Should an older person definitely not get 6 months? The data also doesn't necessarily definitively indicate that. But I think, some of this is adding both some incorporation of how the severity of patient's disease. And there's a lot of factors that weren't included in these high risk and low risk groups: tumor deposits, poor differentiation. So there are other factors in there, as well as, how the patient's doing and patient preferences.
Yeah, I mean, I try to think of adjuvant therapy as having goals. My goal in any patient is a minimum of 3 months of doublet therapy. And when I want to get to 6 months, I think of it as I have a minimum threshold of oxaliplatin. My goal is to get to 6 months, but that has given me freedom to just continue oxaliplatin partway through that second half of therapy.
And I think that's totally appropriate. Yeah.
And what about older patients? You referenced this briefly, and we talked with Dr. Ng recently about young onset patients where more is not better. What about older adults and their ability to tolerate therapy and how they do with these?
Yeah, so it's a good question about older patients. So, there's actually been a lot of studies looking at this, right? So Nadine McCleary and I published a study in the JCO back in 2013 using the Accent database. So the Accent database has been a collaboration of essentially an international collaboration of essentially all the adjuvant trials that have been conducted in colon cancer. And it looked at the first sort of 12,000 patients who were randomized to the studies that included more than a fluoropyrimidine. So 7 adjuvant therapy studies. And what we looked at is, if we focus specifically on the studies that included oxaliplatin, the 3 studies, the patient and the cutoff for that study was greater than 70. The patients who were greater than 70 seemed to experience reduced benefit from oxaliplatin. There was still a benefit there, but it wasn't statistically significant. And we see that in other data. So Hannah Sana, for example, looked at this in the SEER database. There's been studies within Mosaic. There's been studies with some of the other studies. Within IDEA, it's also been recently published. We'll discuss in a second. All of them suggest that older patients can benefit from the addition of oxaliplatin, but it is a more modest, and you really do have to weigh this. I also think, and I think there's general agreement, that age alone shouldn't be the factor that we consider. And should we add oxaliplatin? Should the duration of oxaliplatin be shorter? A lot of this is the functional status. And I think we still struggle in oncology how to incorporate different measures to look at both functional status, biological aging, and other comorbidities, and how we incorporate that into some of the decision making we have.
Yeah, that's helpful. And what are some of the other factors that can impact outcomes? You've published on exercise and BMI. So what else can patients do, and what are patient factors like that contribute?
What we and now many others have looked at is other factors, as you point out, and these are factors a lot of patients ask about. Should I exercise? What should I eat? Those type of things. Sort of in a quick summary, we published 2 observational studies. They're prospective observational studies. One came from the Nurse Cell study. One came out of CLGB 8903, which was a study looked at irinotecan 5-FU and leucovorin versus 5-FU leucovorin, where we added questions about lifestyle patients did. So different medications they take, supplements, exercise, and a food frequency questionnaire. And what we showed is those patients who were more active after their diagnosis and continuing after adjuvant therapy had an improvement in outcome. We use this metric called METs, which is metabolic equivalent test units. The sort of quote unquote optimal was at least 18 METs, which is essentially walking 30 minutes a day, 5 days a week with a pace of at least 2 to 3 miles per hour. So something that gets your heart rate up a little bit or makes you a little shorter breath, and trying to do it most days a week for at least 30 minutes. You obviously could do different type of exercises. And that's now incorporated in the guidelines for exercise in cancer patients from multiple different groups. And that's also been shown in by others in other observational studies. There's currently a randomized study out of Canada specifically trying to intervene in exercise, and we'll wait those results. We published some on diet. Some of the diet stuff's been a little mixed, but generally trying to maintain a diet that's lower red meat, processed meat, and carbohydrates and or glycemic load seem to have a better outcome. BMI is a little challenging. BMI, we know increasing BMI, body mass index is associated with a higher risk of developing colorectal cancer. We see that the BMIs in sort of the 25 to 30 range, which is considered overweight, actually seems to do a little better. Some of that may be related to muscle mass, and we published some on muscle mass as well as others. But BMI is greater than 32, so the class 2 to 3 obesity seem to have a worse outcome. So maintaining a healthy body weight, but also maintaining some level of muscle mass or resistance training may be helpful. Lastly, there's been a lot of observational studies looking at aspirin as well as other COX inhibitors. Part of the study that was done in the United States looking at 3 versus 6 months was second question was acelecoxib versus placebo. It did not reach statistical significance, the overall study. We are soon going to publish on some subgroup analyses that do show a pretty big difference for those who receive acelecoxib. So there may be subgroups. We also await multiple aspirin studies that have fully accrued, but not yet published in terms of understanding what the additional potential benefit of COX inhibition and the COX-2 and NSAIDs in colon cancer patients.
Excellent. That's super helpful. So what I hear from you is that there are things that we can modify, that there's a lot going on in adjuvant therapy, and we have some more data coming that may refine some additional measures that we can intervene on from the American study that you helped lead and others. Today, we've had Dr. Jeffrey Meyerhardt discussing adjuvant therapy for colorectal cancer. We covered a broad range of trials over really 20 years, starting with Mosaic showing the benefit of 6 months of FOLFOX over 5-FU and leucovorin, which was a clear benefit in the stage 3 group. And there was a numerical benefit for high-risk stage 2 patients, but not for all stage 2 patients. We then focused in on the IDEA study, which was a collaboration across multiple trials, 6 pooled analyses, ultimately showing that for many patients, 3 months of adjuvant therapy with oxaliplatin plus fluoropyrimidine is adequate, but that 6 months of therapy still has a benefit for higher risk patients. But for those who are having difficulty tolerating adjuvant therapy, you can discontinue the oxaliplatin, but continue 6 months of fluoropyrimidine with preserved benefit. We also heard that there's data coming out about the role of other agents such as COX inhibitors, and finally the role of exercise and BMI, that increased amounts of exercise improve outcomes, and that patients with a moderately elevated BMI, more associated with high muscle mass, may have improved benefit, but the more obese patients, that's less so. Thank you for joining us. This is Dr. Benjamin Schlechter for In Discussion.
Thanks for listening to Medscape's In Discussion Colorectal Cancer podcast series with our host, Dr. Benjamin Schlechter. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on colorectal cancer.